Thank you for being here, for the chance to join the work we did all together, because this is for sure a collaborative work of which I'm humbled to say thank you to you all. And also thank you for the stage of presenting what we have done here in the last 3 years all together in order to proceed with knowledge, in order to spread the message to the world, and in order maybe to give better answers to our athletes with the questions of what do I have, why do I have it, what's my return to play, and how can I prevent it? And with these 4 questions, we went on a journey in ankle pathology on the lateral ligament, because we know it's a common thing, but we still have so many unanswered questions that we wanted, from our little point of view, try to develop something that hopefully makes a difference. And thank you for the time to go on a journey together on the next half hour to present what the work we've done and the questions that have arisen because of that, and that's why it's an ongoing story. I have no disclosure to this talk, and basically this is what we're going to talk about. What do you see here? You would all say we see somebody with a bad ankle sprain. I hope you agree with me. Well, it doesn't exist. So that's the controversy we want to discuss today. Why doesn't exist? Because if you look at this picture, this is the most common injury in the world of sports overall. This is the 3rd most frequent injury in the world of football. Hamstrings is first, and we already have a lot of PhDs on that also. So we're ruling the waves here altogether. But this is also in the world the #1 contact in the emergency department. So we're not talking about some rare thing. We're talking about the most common injury in recreational and maybe even competitive sports overall. So this is the picture that we will discuss throughout the next minutes. Now, you've all been working in emergency departments or related to it, or acute sports medicine, or acute sports traumatology, or even performance. All these things, if you talk with your peers, your supervisor, or whatever, if you have a knee injury in your OR or in your emergency department, ER, what do you say? You call the person and you say, look, I have a knee sprain. Would you do that? How would you do? What would you say? You would say, I have a patient here, a player. He twisted, he heard a pop. He might have some instability. It's an angry knee. Maybe he has an ACL or she has an ACL injury. Or you will say, I have a patient here, locked knee, probably a meniscus. Or you will say, I have an effusion in the knee, probably a cartilage lesion in a youngster. You would say it like that. You would not say, I have a knee sprain. You agree with me? So why you say it on the ankle? We all say it, do you? You agree? We all say, patient referred to MRI, ankle sprain. Patient referred to rehabilitation, ankle sprain, grade 2, 3. Doesn't make any sense. Why? Because it doesn't exist. So here we go. All right, you ready? So my journey started when I had the great privilege of joining a paper here that we published all together in American Journal about 5 years ago. And simply the outcome, we had the chance of, in every athlete with a so-called ankle sprain that came in, we were able to do an MRI. That MRI showed that in 20% of cases, an acute ankle sprain had a combination with syndesmosis. Now, syndesmosis is what we call the high ankle sprain. That doesn't make any sense. And that's why we started this journey, because it doesn't make sense. We need to understand that better. Why it doesn't make sense? Because an ankle sprain, so-called ankle sprain, is in plantar flexion and inversion. You agree with me? Most commonly. A high ankle sprain is in dorsiflexion and external rotation. Doesn't make any sense that that is a combined injury. So what's happening there? Let us find out, or maybe find some clues in order to know how to proceed and understand that better, because if we understand it better, we're going to treat it better. I got this video from Nickel van Dijk. It's an awareness test.
How many passes does the team in white make?
Some of you saw it. How many passes does the team in white make? How many?
The answer is 13.
13. Now,
But did you see the moonwalking bear?
it's easy to miss something you're not looking for. And this is basically what we're trying to discover here. Ankle sprain, high ankle sprain. Let's still call it like that. Hopefully not until the end. Yeah, I got that. So it all comes from cycling overall, as you can see. Now, can we put that music down here? Anyway, you'll have to bear with me with the music. Look at the mechanism of injury. Yeah, thanks. So we will start first with the high ankle sprain. We will then go to ankle sprain and then some little extras. The high ankle sprain means AITFL, IOL, PITFL. And that's the fork in the ankle that resists axial, translational, and rotational forces. So that's really important in the... Thank you. Anyway, let's proceed with that. You've seen the mechanism of injury. It has nothing to do with an ankle sprain. It's a dorsiflexion external rotation injury where you have these very different presentations of over the ankle overall. So when you look at high ankle sprain, let's start from the height. We talk about syndesmosis. When you look at literature, you have two papers from intercollegiate sports in America that show what is out there from various sports. You have nothing sport specific, believe it or not. So what did we try to do? We had the chance to team up with the great database of the UEFA study under the leadership of Professor Ekstrand, and we had the opportunity to follow teams over 15 consecutive seasons. Now that's credible data. And what did we see? We saw that from these Champions League teams, these elite teams in football, we saw that there was an injury incidence during match play much higher, 14 times, than during training. We saw that there's a 7.5 annual increase in the injury incidence, and we've seen that it's mostly contact related. Most of these absences are are 5 weeks or more, so much more than the regular ankle sprain. So that's what we know now, that is out there. Now then the next step, after epidemiology and mechanism of injury, we had to understand how to proceed with that from a clinical imaging point of view. And we did a comprehensive literature research, and we came up with 3 pillars of clinical examination, meaning listen, look, feel. Listen at the mechanism of injury, listen if there's radiation up, look if there's anything related to ecchymosis, to bruising, and look at the imaging if there's an open space on the X-ray. And feel, do all the tests. Although they're not pathognomonic, they help you in the assessment. It's like a menu. You have different things, you put it together, and your puzzle becomes more clear. But is it really? Because you have grade 1, grade 2, grade 3. Grade 1 never needs surgery. It's a mild sprain of high ankle sprain. Grade 3, always, because it's all ruptured. But predominantly, 80% of all injuries are grade 2. And that's where we say maybe surgery. Now, if you have your athlete or your manager of the team or your performance person that follows the athlete, and you say maybe, doesn't get very far, right? You need to have an answer. We don't. So what do? We look at the imaging and we look at the mechanism of injury. Now, if it's a fracture, it's easy. You see, there's an open medial deltoid rupture, there's a big cartilage lesion, the syndesmosis is completely open, and you have a fracture. That's what we call the typical supination external rotation injury. What do? Look, this is the mechanism of injury. You fix it, done. And the most important thing is that you have your congruency in the joint again. All the rest is not important. And the reason why I have put this slide is for the following reason. Whether you have a fracture, whether you have an ankle sprain or you have a high ankle sprain, we all rehab them the same way with our own specificities. We don't have a validated, standardized protocol. And since the mechanism of injury is so different, that doesn't make any sense. So it's a real message to you all, especially in rehab, help us out, because we need to validate and standardize the typical mechanism injury with the typical rehab strategies. And it's really out there and it's not been done. So I would really recommend you, if there's one thing in a thesis, it's that brings forward future questions. And please help us to find a way in order to validate and specify these injuries and make it better. Because it all works, because the ankle is so congruent and forgiving, but over time it doesn't. So really, this is a message to you all. Another example, for example, is a guy from abroad that came to us with this X-ray. He came in with a cast. He was told in 4 weeks you can remove the cast and play again. Now he has a simple Weber-Bay fracture, as you can see here. Totally agree. But does he really? If you look at the imaging, he opens on the syndesmosis. The medial side is more open than the tibiotalar area. So this is a bit of a strange picture. Even without stress radiographs, you have to ring a bell. And then you go back to the mechanism of injury and look at his foot. You see full dorsiflexion, full external rotation. That is not an ankle sprain. That's not a little fracture. In cast, that will heal, but will it really? Because if you fix this and you do arthroscopy, you see the whole syndesmosis falling into the joint. You see the interosseous ligament completely in with soft tissue impingement. On the medial side, you see the superficial deltoid completely ruptured. You see the deep deltoid completely ruptured. So I agree, this is a fracture that you need to treat. But this is mainly a ligamentous injury. This is a floating ankle where you happen to have a fracture. So if you only focus on the fracture, you did not help this athlete. It's finished. So you have to understand what's going on. And that's where our new data hopefully can help. But if you look at the literature, we were talking about the stable or unstable grade 2s. What does the literature say? If it's a fracture, you fix it. If it's not a fracture, or it's stable or it's unstable. Very simple. But what is stable and what is unstable? We don't have guidelines. So the literature says, the systematic reviews say, if you have a combined deltoid injury, but that doesn't make sense, because if it's combined deltoid, it's a grade 3. So this is not a grade 2. It doesn't help you. If it's a positive external rotation test, it's positive. But the validity and the new work from our group with Thomas Baltes and the other principal investigators is showing that there's such a variability in the testing. So all these things are nice on paper. They don't help you because it's not clear anyway. And then if there's tenderness over the interosseous, what does that mean, tenderness? Of course you have tenderness. Once you have a pain over the ATFL, it goes all over the place. And you have a suspicion of widening over X-ray. But you know that grade 2s, they don't widen. So all these 4 help extras in the systematic reviews actually don't help you in practical. So we're still nowhere. We don't know if it's stable or unstable. And that's where literature says, if you don't know, I hope I can proceed here. If you don't know, you do an arthroscopy. I hope the videos will work. No, they don't. Let me have a little look here, if we can get there. No, well, you have to take it from me that there are 2 ways to identify instability over the syndesmosis, and that's both by arthroscopy. I have to push. Well, it's the probe test and it's the shaver test. It's very simple. You push the probe in and the shaver and you see if it opens or not. So that's the golden standard of what we can know by now. But that means that every athlete with a grade 2 that you don't know, you do surgery for. Now, that's very aggressive because many of them don't need it. And then that test is a good test in experienced hands, but it doesn't mean it's always very clear. So we're still not completely there. So what did we do? And I have to recognize the rehab department big time, together with especially Slim Bohdida, that developed this device, is that we sat together and we say, what can we do to avoid the fact that we have to stretch it to arthroscopy for many things that are not necessary? And we said, we're going to make a device with all these cool tools that we have here in order to reproduce the injury and to see if there's an apprehension. Because we know from cadaveric lab studies that we did that an syndesmosis opens in between 87 Newton and 100 Newton. That means if you have an apprehension before 87 Newton, you have an unstable syndesmosis. And we validated that, blinded that. So I did 15. We had an ethical committee approval. We did 15 consecutive arthroscopies and blinded with the test that we did with Slim. And we saw that when you put the board neutral or in plantar flexion, there's no correlation. But spectacular correlation when you put it in dorsiflexion. So every time I saw blinded an instability, Slim saw the same on the device. Now that's only an underpowered study, only 15 players. but it shows a tendency, and we hope in the future we can progress with more cohort people in order to show that we might find a very important tool combined with our clinics, combined with our imaging, in order to identify instability of the syndesmosis without having to do arthroscopy, or at least doing arthroscopies that are not necessary. So that's a good start, and that's a message from Aspetar to the world, and hopefully we can extend that and extrapolate that with collaborative moments. So this is the way this video works. So this is the way we do it. We push with our mechanotransducer, we stabilize the knee, and we see if you have an apprehension, and we can then identify the Newton on which the apprehension was done together with our EMG markers, and that shows instability or not. But we took it a bit further, because if you do arthroscopy, as I said, the golden standard, if you look at literature, there's no guidelines. It says expert opinion. What does that mean, expert opinion? It means the sum of all your failures. That's experience, right? So it doesn't make sense to say all do arthroscopy and we know. Why? Because the grade 2s are mild. And that's where we said, we go to the cadaveric lab, we will put a mechanotransducer on the shaver that we use, so we practically introduce, and we did a pilot here in our center, and we did the further testing abroad in the biomechanical lab, and we come up with clear messages of Newton forces that you need to enter a syndesmosis, while we gradually have cut the consecutive ligaments and have seen how much force we need to introduce. Now that's a bit technical. It just shows that when you have a practical test with your shaver or your probe in order to identify instability, that you can now see how much Newton force you need, and that can bridge the gap to develop new tools in order for us to have a better understanding if it's stable or not. So we try to do it non-invasive, we try to do it invasive to find a way. And the last step is now that we finalized an international questionnaire that we now have 800 replies already from foot and ankle specialists all over the world, because we want to know the geographical changes. If you go to conferences, everybody does something different. So we want to map that geographically, see how we fix it, and then what is the rehab time. And then understand what the world is doing, what are the differences geographically for whatever reasons, FDA, ethical committee, and so on, and then come up with a guideline that might be worldwide used. So that's the final step. So far for the syndesmosis. Let's talk about the so-called ankle sprain. I don't have to inform you on the ligaments and the anatomy. You all know. But do you know that, and it's a study from Di Giovanni in Boston, by the way. It started all with that. Do you know that if you do an arthroscopy in every chronic ankle instability that is out there, there is 100% of concomitant injuries, whether it's syndesmosis, whether it's impingement, whether it's cartilage. So that's a big number, right? So there is an effect of chronic ankle stability on the ankle overall. Again, there's no simple ankle sprain. Why? Because it affects all the environment around the ankle. I'm not going to go too much in detail, but for example, this is what you can see. A Bassett's lesion. A chronic ankle instability can induce, in 20% of cases, chronic syndesmosis instability. And you see here a big chunk of soft tissue falling from the syndesmosis into the joint, affecting your game of play, giving synovitis, effusion, and so on. So all these specificities show that there's no simple ankle sprain. So coming back to our player that we presented from the beginning, you have, of course, the images. ATFL is tested with an anterior drawer test. CFL is tested with your Taylor tilt test. You are all familiar with that. And then we do an MRI. We see the CFL is completely gone, and we see the ATFL is completely gone. That's our simple ankle sprain. Now, what did we do when you look at what's going on in the world of sports surgery around the ankle? You see that there's a lot of vibe around doing arthroscopy for repair. Why? Because they say it's a faster rehab, higher precision, and you can identify and treat complementary diagnosis. Fantastic. Arthroscopy is the new thing. And it is. The problem is, ATFL is intra-articular, but CFL is extra-articular. So arthroscopy means in the joint. So if you're going to do a repair of your ATFL, perfect. But what about the CFL? you've seen on the imaging, both are torn. You don't address them. So in a way, you just do what we all do with physio, which is refixing with good elastic tissue the torn ligaments or the attenuated ligaments. So actually, are we really doing the right thing? Are we using arthroscopy the right way? Because we don't touch the CFL, because it's extra-articular. And that was the instigation of our next question. We wanted to know, what is the role of CFL in these kinematics? And our aim was to evaluate the impact of a CFL injury on the ankle, stability, and biomechanics. And we hypothesized that both injuries will result in alterations in these mechanics. So, again, the sound. Anyway, you'll have to bear with me with the sound. So what did we do? We did a load to failure, and we added an instrom to check stiffness and torque, a motion capture, and a tech scan in the joint. So we combined all three together. What is it doing kinematically? What is it doing in torque and stiffness? And what is the pressure on the cartilage? And I won't have sensitive comments here, but this is what we did to identify what's really going on. And all these studies have been done separately, but never together. So that's never given an in vivo idea of what's going on. Now, the stiffness is, of course, the extent to which an object deforms, resists to deformation. And we saw that if you just cut the ATFL, it doesn't decrease. But if you cut the CFL, it decreases in addition to 37%. The change in torque, the force that creates rotation, did it increase with ATFL? Decrease? No. Did it decrease with CFL combined? Yes. So you see me coming. Then we looked at the subtalar joint, because you know the CFL is a B-articular ligament. It goes over the subtalar joint also. So what did we see? It shifted medially when you cut the CFL significantly. What did we see in inversion of the joints? It significantly altered, more in inversion, with the CFL, as you can imagine, and at a higher magnitude because we added weight bearing in our testing device. So what is it saying? Also the peak pressure, I told you we were checking the pressure on the cartilage also. We see that it decreased after CFL sectioning. So that highly congruent ankle joint that is normally so tight and so congruent, when the CFL is cut, it suddenly becomes one loose thing. That's what the study shows. And very interestingly, you all know that when you have chronic ankle instability, most of the injuries are posteromedial. And now we know why. Why? Because the center of force changes. So if you have an over and over instability, the center of force goes from medial to posteromedial. And that's probably, and most, we are sure about the fact because it's significant, the reason why these injuries in the cartilage are chronically over the posteromedial side of the ankle. So what does it tell us? The CFL clearly contributes to joint stability and kinematics, and the higher appear to result in substantial alterations with ankle kinematics and biomechanics. So yes, the CFL looks important. And then look at the cartilage. There's a huge shear force in inversion on that lateral side of the cartilage. That's why the acute lesions are always anterolateral, because of the shear forces. And that's why the chronic lesions are also always medial, because of the impaction that it has through these repetitive inversions. So what can we conclude? What are the implications of our study? The repair should be considered, even in the minimal invasive procedures. So yes, arthroscopy, if you want to do a good job, you will have to think with CFL included. And then also there may be a role for acute repair. That's controversial. But if you look what CFL does on the alterations of kinematics and joint stability, you cannot go beyond it and say that it's okay just to keep an eye on it. No, you have to make sure the congruency is back. Now, we not just tested it, we also repaired it. And in these cadavers, we then repaired it, and we saw that it made sense over the ATFL and CFL complex to repair furthermore, but that's a bit technical. I won't go too much in detail on that. We were humbled by the rewards we got with this work, but especially with this amazing team that I was honored to join, and that just is delivering what we wanted. We were 3 days in a day and night bunker trying to figure out how to do things, and luckily it went all well. And I have to give kudos to all these guys. Okay. Epidemiology, mechanism of injury, clinical imaging. There we are. But what about the treatment? Now, if you go to high ankle sprain again, we did the literature on the review. We did a review on the literature. That's maybe better. And we found out what is best, what is out there to know how to treat them better. You can use screws. How to put them is a bit technical. I won't go into that. You can use screws. You can use suture buttons. It's all there. The advantage of suture buttons is that it's a bit faster rehab. You can walk faster. You can move faster, so less stiffness. You have less implant failure. But especially, you have less malreduction. Why? Because believe it or not, we're always proud of our work, all of us, but sometimes if you look at the results, up to 52% of reductions of syndesmosis in the world literature show still malreduction. Can you believe it? So that's something we have to work on furthermore. And the remaining diastasis can be up to 22%. So we know now how to fix it, better to fix it, and with which tools we can increase the quality of our treatment. But still we have a malreduction. And that's another question for us for a future thesis, probably. What is normal? Because the variability in all these scans is so high that we call it malreduction, but we actually don't know the standards because everything's different all the time. And that's still the question out there, so a little tickle to the guys who are interested. And then we did a paper that we published in the American Journal saying that the syndesmosis, the suture button and the screws, they have a specific way of fixing, and the suture button for the moment is predominantly better compared to the screw if you consider malreduction and implant failure. But for other things like functional outcome, there's not a real significant difference. So that's what we could see. So we've dealt with the ankle sprain and the high ankle sprain. But as I said, chronic ankle instability is not just a simple ankle sprain. It affects the environment. And I want to run through two things with you, which is impingement and cartilage. Impingement, you know what it is? You can have anterior impingement that blocks the movement in the front of the ankle, and you have posterior impingement. Now we know that 30% of people with chronic ankle instability have ankle impingement in the front. But we've never identified anything on the posterior side. And what did we do? During arthroscopy, we sometimes saw when you release the flexor hallucis longus, a posterior arthroscopy, you see the thickened musculotendinous junction. It's squeezed in between that canal. And we saw that if you have combined chronic ankle instability, it's just moving too much. It's not a normal movement. And then we said, what are the clinics of that? The clinics are a hyperplantar flexion test. You see, we do a little hyperplantar flexion, and the apprehension is there. So what we did then is go back to our players. And we said, okay, we have 80 professional athletes in our cohorts. 40 of them had osteoarthritis with clinical signs and surgery. 40 of them had clinical signs and imaging, but no surgery. So many of the players have osteoarthritis, but we want to know why do you have surgery for it and why so many don't, because it's not all traumatic. And what did we do? We combined them in two groups. And what did we see? We saw that a lot of them had combined chronic ankle instability. And it makes sense. If you look at that area of conflict, if you have more a shift towards the front, and then you have a plantar flexion or a hyperplantar flexion, you simply have more conflict. Makes sense. But what is it really saying us? When you look at the binary regression model that we had, that we did with our statisticians, Karim and Montasser, we saw a spectacular increase in surgery, 10 times more chance of having surgery for this if you have a combined chronic ankle instability. Now, that's a message. That shows that chronic ankle instability has an effect on osteoarthritis, and that tells us that if we can treat the instability with somebody with osteoarthritis, he probably or she will never need surgery. So this is a big preventative statement. And then the other thing is the cartilage. We published in Foot and Ankle a kind of consensus on cartilage, because we looked at what is the rehab of a cartilage lesion. And as you know, 30% of people with chronic ankle instability have cartilage lesions, so it's all related. There's no simple ankle sprain. So what did we see? We saw the current evidence is so low. Low cohorts, low statistical value, low quality overall. So we gathered, we were part of the invitation of being gathered in Pittsburgh in order to do a Delphi method where we created groups and came up with consensus statements. That doesn't mean it's high evidence. That just means that the people who do this frequently think this is the best way forward, and that's the basis of new studies in order to proceed. And what did we find? We found answers to questions like, how fast can you weight bear after a cartilage lesion? What's the return to play in combination with ankle instability? What if you have a combined osteotomy or concomitant procedure? What is the psychology effect on all these things? Questions that we answered, questions that built new questions, and questions that hopefully will progress with new answers in the future. So that was a very nice combination with impingement and cartilage related to that instability. And I want to end with the cherry on the cake, which is what we all are most interested in. It's the return to play. But bear with me. If you look at the hits in PubMed, in Cochrane, in Embase, in all these amazing databases, on chronic ankle instability, repair and return to play, you have so many hits. Of course, it's so frequent. But if you look at the clear inclusion criteria and you exclude the lack of data on return to play, you come up with 20 articles that show some metrics on return to play timeline. So there's a clear deficiency in literature, and we need a more defined structure for assessing readiness of athletes' return to play in that most common injury in the world of sports, ankle sprain, which doesn't exist. So in a way, what I can say from this study, that systematic review that we did, is only 5.5 of papers on return to play timeline metrics show some sort of quality information on return to play. So it's all our responsibility that if we want to progress in a better way, that we do it better, that we document better, and that we analyze it better, because otherwise we're never going to talk the same language and we'll never come up with validated return to play guidelines. And if you take that further to arthroscopy versus open, as I hinted a few minutes ago, you can see that if you look at all this data and you exclude all the less relevant data on return to play, you see that there was only 10 studies, and that was last year, so more have been coming out now. But there's a huge lack of literature that helps us furthermore, and that's in a nutshell what I want to say. But the last study I want to present is our study. It's really the work of all of us, from NSMP to rehab to performance to research to surgery to sports medicine. So I want to end with this because I'm very proud of this one for the simple reason that this is a purely surgical outcome Aspetar paper that I dare to say that is the first one that is methodologically from the surgical department well done, and that has been highlighted the collaborative strength that we have under this house in this umbrella. What did we do? We looked at MR confirmation of syndesmosis injury in 110 male professional players. We looked at the clinical picture and we excluded fractures and stable injuries. And what did we come up with? We came up for the first time where your athlete asks you, what is the return to play after syndesmosis? And we come up with an answer to say, look, within this variability, you can expect this. If you have an instability, your return to field is 37 days. If you have a return to train, it's about 72 days. And a return to first match is about 103 days. Now, this is valuable data. If Dr. McGuinness with his team comes and he has an instability of the syndesmosis and he asks me, what will be the return to play of our players? We never knew the answer. Well, we dare to say that thanks to all these collaborative efforts from all of us, we can tell the patient, the player, and the staff around, you can expect this. And that's a message to not only our players, but hopefully in the future to the world of sports. And we also added the fact that if you have a young age, if you have a combined deltoid injury and a cartilage lesion, or if, that these three are the predictors of a prolonged rehabilitation. So if you have these three, you have to say this data will be extended by this and this amount. And that's in a nutshell what we have been doing. I want to end with this video just to say that there's no thing as a simple ankle sprain. So every time we talk now on an ankle sprain or a referral, let's tease each other and not do that anymore. Why? Because we believe it's not important. It's or a tendon, it's or a cartilage lesion, it's or a stress fracture, it's or an impingement, it's or a combined instability, it's or a syndesmosis, but it's not an ankle sprain. And what is the future? The future is that a lot of this work is purely static. It's not neuromotoric. I know that very well, but it's a start, and hopefully other people can build on this work. We have to address the CFL through an endoscopic procedure because it's not intraarticular. Arthroscopy will not help it. We need to identify better how to speak the same language with telling the same data and evolving towards discharge criteria. The malreduction syndesmosis, as I've shown you, is still a big thing to evolve with. There is a link between posterior impingement and chronic ankle instability, as we've shown, but we don't really know exactly what is the extent of it. Cartilage is the ultimate victim and still a big problem in our treatment protocols. And the overall big dream is one day, just like in the knee, to create a device where we can talk the same language, validate instability, and then use that as a step up to become better in our treatment and prevention strategies. I need to thank everybody who collaborated with us, Aspetar, the university that I had the chance to do the thesis, and all these other people that throughout our journey of the last 3.5 years have tickled our interest and have given us the chance to open up their labs, to open up their collaborative projects. And of course, it's always a family thing, so I'm very grateful to my family to support me in that, because as you all know, that it has an impact on all of us, and it's just great to have the feeling and the support in that regard, and I highly recognize that. In line with that, we had the chance to develop with a lot of great people some books that are relevant to the topic, and I'm happy to share it with you. And thanks again for all.